Hello, and welcome to the webinar hosted by the Pennsylvania Medical Group Management Association. My name is Erin, and I'll be your host for the day. I'm pleased to introduce our first speaker, Matt Davino. Matt is the Associate Director for Government Affairs for the Medical Group Management Association. In his primary role as a government affairs member liaison, Matt works to inform membership of the federal rules and regulations impacting medical group practices around the country. He works closely with MGMA state affiliate chapters in the eastern and western regions to organize grassroots efforts and is a frequent speaker at state and national meetings. We're excited to have Matt with us today. We purposely waited to schedule Matt's engagement with us this year until after the national elections, but Matt and I were just chatting that we don't know much more than we did before the elections, do we, Matt? But we are happy to have him with us, and we're excited to hear his presentation. Matt will give us his presentation, and then we will be able to ask some questions of Matt when he is all done. Thanks. Take it away, Matt.
Thanks so much for the introduction, Erin, and thank you for everyone joining today, and happy to share all of these legislative and regulatory updates with you all. As Erin mentioned, we are about a month after the national election at this point, and do have some additional clarity. I would say there's been a lot more movement on the regulatory side of things rather than legislative, and have somewhat of a clearer picture going into 2021. But I think a lot is still up in the air. But I'm happy to talk through all the things that we do know so far. There is quite a lot. And as Erin mentioned, I'm happy to take questions at the end. I'll leave about 10 minutes to do that. So to just go through our agenda for this afternoon, I'll start with the Medicare payment landscape, which it is seeing some changes as a result of the release of the 2021 Medicare physician fee schedule. Just last week, the final rule was released, and so there are some updates on that compared to the proposed rule. I'll review that in regards to MIPS, as well as alternative payment models, and then talk about some more specifics in the fee schedule, such as updates to E&M, and some other payment policies. I'll then move into the COVID relief section. I know there's a lot of programs that are kind of being juggled right now in regards to the financial side of things for medical practices. And so I just want to address updates to those programs, including the Provider Relief Fund, the Paycheck Protection Program, the Accelerated and Advanced Payment Program, and just briefly touch upon Medicare telehealth flexibilities. And then I'll wrap up with a congressional outlook through the rest of the year into 2021, and finish with a discussion of MGMA advocacy and member engagement. So to just begin with MIPS, the Merit-Based Incentive Payment System within the Quality Payment Program. The first quick note here is that if you haven't seen them yet, for any MIPS participating clinicians, the feedback and final scores are now available for the 2019 performance year, which affect 2021 payment adjustments. You could see those by logging into QPP. And again, these adjustments will take effect January 1st, so just make sure that you're aware of those, and will affect Medicare Part B payments. To just do a side-by-side comparison of 2018 performance to 2019 performance, there aren't a very significant change in the payment adjustments that we're seeing. We saw a max adjustment of 1.68% positive change for the 2020 payment year. That has increased slightly for the 2021 payment year to 1.79% as a maximum. That's because 96% of MIPS participating clinicians scored higher than the neutral performance threshold. And so, there was not very much money to pull from on the penalty side, and so your higher adjustment was lower than initially anticipated, that +7, but the maximum negative adjustment was -7%. Nobody achieved a negative adjustment for the 2019 performance year. The remaining 4% all got that neutral adjustment. And again, these are reflected on your Medicare Part B claims and in the form of the adjustment codes shown on the screen here. Looking ahead for the 2020 performance year, I do want to make a note that CMS has extended the extreme and uncontrollable circumstances hardship policy, whereby if you are unable to report or need to reweight any one or more MIPS performance categories, you can submit an application by February 1st. And so that would need to be completed by 8 p.m. Eastern on that date. It's possible that could be extended more. This past year it was extended, and they also did an automatic extreme and uncontrollable circumstances policy. We haven't seen that done yet. It's still proactive to apply for. So it's something we're continuing to monitor, but currently as it stands, the deadline is February 1st. And a note that if you do report any group or individual level data, that can override one or more performance categories that have been approved for this hardship. So just be aware of that. I also just want to make a note, if you haven't been on one of my presentations before, I like to include a lot of hyperlinks to resources and educational materials. So I've made my slides available, and definitely feel free to use those as a reference. So I do want to compare the MIPS performance years 2020 and 2021 side by side, just to see the changes that have been finalized in the 2021 final rule for the Medicare physician fee schedule. The positive and negative payment adjustments are going to remain the same. That's plus or minus 9%, and no changes to the reporting periods. The category weights are changing for MIPS. From 2020 to 2021 performance period, the quality category is decreasing by 5%, and the cost category is increasing by 5%. No changes to data submission. They originally were planning to phase out the web interface for 2021 reporting. That has been delayed until 2022 in the final rule, so no changes there. The complex patient bonus was increased to 10 points for 2020. It'll go back to just 5 in 2021, and no changes to the low volume threshold or EHR technology. Oh, this is showing up in a fun order. So again, I just will compare side by side the 2020 to 2021 point thresholds. Again, these aren't really changing very much. The big change here is that the neutral performance threshold to achieve a 0% payment adjustment is increasing from 45 points to 60 points. So that is quite a big increase, but I will say in the data that CMS released on 2019 performance, the vast majority of MIPS participating clinicians were scoring above 75 points. And so it should still be possible to avoid any sort of penalty in this program if you're complying with, the basic requirements of it. The exceptional performance threshold is still staying at 85 points from 2020 to 2021. And so that's where that additional incentive payment would come into play. Now to switch gears a little bit to the other arm of the quality payment program, that would be alternative payment models, and specifically advanced alternative payment models, or APMs. These allow eligible clinicians that become QPs or qualified participants to actually receive a 5% APM bonus payment and exclusion from reporting for MIPS. So all of these programs on the left side are considered advanced APMs for the 2021 performance year. Some of those are being carried over due to model timeline extensions due to the COVID-19 pandemic. But you could also see there at the bottom, there are some brand new models that are beginning performance for the first time in 2021. That's Primary Care First, the direct contracting model options, kidney care choices, including both Kidney Care First and kidney care contracting. And finally, the radiation oncology model, which I'm going to talk a little bit more about because unlike all of the other APMs on that list, that's actually a mandatory model rather than voluntary. The benefit I mentioned is that 5% bonus payment, but CMS did finalize these higher QP thresholds for 2021 to actually become a QP and achieve that bonus payment. The clinician or entity must receive at least 75% of Medicare Part B payments or 50% of Medicare patients through that APM entity at one of the determination periods in order to become a QP. That is quite a sharp increase. And so anyone involved in value-based care and APMs, we are advocating for congressional action to change those thresholds just to still make it possible and desirable to participate in advanced payment models. So I mentioned that the radiation oncology model is a mandatory model. You can see under participation here that CMS does require participation for certain radiotherapy providers that fall into specific service areas by zip code. So there is a hyperlink there if you are a radiation oncology provider providing radiotherapy services. Definitely take a look at that, because you may be mandated to participate in this program, which makes prospective and episode-based or bundled payments for 16 different cancer types. This does qualify as an advanced APM, so you could receive that bonus payment even though you're being mandated to participate. And this program was originally supposed to go into effect January 1st, but due to advocacy by MGMA and other associations, it was delayed until July 1st, so some extra time if you are going to have to participate. There is a second mandatory APM beginning next year that does not qualify as an advanced APM, but again, this is coming down to those specific geographies. So certain zip codes by geographic area are being mandated to participate, and these are ESRD or end-stage renal disease providers. The model is hoping to test whether greater use of home dialysis and kidney transplants for Medicare beneficiaries will reduce Medicare expenditures. And so please, if you're a nephrologist and or offer ESRD patient services, check in and make sure whether you're going to be mandated to comply with this program. It does go into effect January 1st. I do now want to touch upon the final rule for the 2021 Medicare physician fee schedule, which, as I mentioned, was released on Tuesday evening last week. So the MGMA Government Affairs staff has been poring over all 2,000 pages of the rule to analyze it as closely as we can. We are producing a full analysis later this week that will be available and sent out to MGMA national members. But to touch upon some of the major provisions of this final rule, CMS did confirm this sharp decrease to the 2021 conversion factor for Medicare payments. It is a decrease of 10.2% for both the physician fee schedule and for anesthesia. So in our comments and in the comments of many trade associations, we were advocating against such a drastic decrease to the Medicare conversion factor, but CMS did not comply with that. Basically, what they're saying is due to budget neutrality constraints and increases to RVUs for particularly E&M, outpatient and office visits, they needed to adjust the conversion factor to maintain budget neutrality that's mandated by Congress. And so there is this drop to the conversion factor as a result. That is going to affect different specialties differently. So if you are a specialty that bills E&M a lot, you will see up to 15% increase overall on your Medicare payments beginning in 2021. If you don't bill E&M very much, if you're a specialty that is more procedure based or not direct office visit consultations with patients, you could see a decrease of up to, I think, 10 or 12%, and that is covered in that final rule. So please take a look at that and our final analysis if you're able to do so. And just to show you how that kind of factors into the Medicare services payment calculation, you've got your conversion factor there at the front. That's the item that's been decreased by about 10% from last year. That gets multiplied by all of your RVUs for work, PE, and malpractice, and then factors into your MIPS adjustment that we talked about earlier. And finally, by the sequester, which has been suspended through the end of this year, but short any further congressional action will come back into play January 1st. And then you get your Medicare payment. I do want to go into a little bit more detail on those evaluation and management, or E&M, changes for 2021. We've known that these are set to come for a while now. They were set in the 2020 final rule and then confirmed in the 2021 final rule. But CMS has decided to eliminate the level 1 new patient visit code 99201 and maintain separate payment levels for the remainder. That's level 1 through 5 for established patients and 2 through 5 for new patients. They've also created 2 new add-on codes for these E&M codes. So you would be able to add these on when billing for both new and established patients. The visit complexity code was originally supposed to be GPC1X. It's now been renamed G2211. And that would be for a part of an ongoing or comprehensive primary care or visit for single or serious complex chronic condition, and it is not specialty restricted. There is another code that was intended to be used for prolonged visits, and it was originally called 994XX, then renamed 99417 by the CPT editorial panel, and ultimately CMS decided they did not agree with CPT and how they'd like to use this code, so they created their own code, G2212. And so that is to be used for E&M visits when time is used rather than MDM. So when you're coding for time and the time for a level 5 is exceeded by a full 15 minutes or more, you would add this code onto that level 5 visit. So there was that discrepancy that's now seemingly been resolved by the use of this code. You have to go a full 15 minutes over, and for every additional 15 minutes, you could continue to tack on that code. Finally, the documentation changes are being confirmed as anticipated. You can bill these office visits by using medical decision-making, or MDM, or total time with the patient, including non-face-to-face time, but on the date of the visit. And CMS is no longer requiring minimum supporting documentation for a level 2. So a lot more education on this is included in the link here from the AMA. So I'd highly recommend taking a look at that if you're billing E&M. Do want to just touch on a couple more regulations that are of note to group practices. First is the AUC program, or appropriate use criteria. Legislation that created this years ago was intended to reduce overutilization for advanced diagnostic imaging technology, and requires professionals that order those technologies to consult a clinical decision support tool. This program began its educational and operational testing period in January of this year, and CMS has delayed full implementation of the program until January 2022, so noncompliance would start to see payment penalties at that point. But this is an advocacy win, just because we are continuing to try to make additional changes and adjustments to this program to make it less administratively burdensome for providers to comply. So we've got a whole extra year of time to continue to work towards that. And then there's the 21st Century Cures Act, which many practices plugged into the health IT landscape tend to ask about. There were regulations that came out earlier this year from the Office of the National Coordinator for Health Information Technology, or ONC, as well as from CMS, interpreting those interoperability, implementing interoperability rules. And the most pertinent ones that were coming into play the soonest were the information blocking regulations. They were due to take effect in November, but that was pushed back in the form of an interim final rule that extends the compliance with that provision to April 5th of 2021. So definitely make sure you're complying with those information blocking provisions by that date, and you can download our 21st Century Cures toolkit to make sure that you are. That was a lot of information, but there's still a lot to cover. I'm going to take a quick swig of water. Obviously, this has been a year unlike any that we've seen, at least in recent history. And as a result of the COVID-19 pandemic, Congress took many legislative actions earlier in the year to create some relief and financial stability for medical practices and small businesses across the country. So the first one I do want to cover is the Provider Relief Fund. This was created through the CARES Act, and through that piece of legislation and a subsequent piece of legislation, Congress appropriated $175 billion to HHS to distribute to healthcare providers in order to account for expenses and lost revenues attributable to COVID-19. These are grants. They are not loans and don't need to be paid back so long as you comply with the terms and conditions and reporting requirements associated with this program. And HHS has been distributing these payments in the form of general and targeted distributions since April. So just to give a breakdown of what that looks like, the general distributions are those that have been available to a general audience, particularly those that see Medicare beneficiaries, but also available to Medicaid and CHIP providers. And basically, it's open to almost every provider at this point. But that has been in the form of 3 different phases. And so if you are a Medicare provider and billed Part B in, I believe it was 2018 originally, you probably got an automatic payment sometime in April that was deposited without you having done anything. That was part of the phase 1 general distribution of $50 billion. You can see on the right there. That was followed by an open application period that allowed any eligible Medicare provider to apply for up to 2% of patient care revenue and receive that as a payment from this fund. That was then opened up to Medicaid and CHIP providers in phase 2, beginning in June. And then in October into last month, all previously ineligible providers were added to that pool, including those that began practice in the earlier part of this year and those that bill private insurance only. And the most recent phase is allowing a bonus payment on top of that 2%. There's a $20 billion allocated as part of that, and depending on how many providers apply, HHS will divvy up the remainder. So there's a potential for bonus, and we haven't heard what that bonus might be at this point. We're continuing to monitor, but that period has now closed. You could see the targeted distributions on the left-hand side of the chart here as well. And then approximately, we estimate $32 billion that's been allocated to this fund has not been distributed or allocated yet. So that's still sitting there for HHS to decide what to do. It's possible there will be more targeted distributions, I would anticipate, due to elevated COVID cases across the country. It's possible there may be another general distribution, but unclear at this point. So the main question for this program now is the reporting and record keeping requirements. Essentially, HHS is saying if you received more than $10,000 from the Provider Relief Fund, you will be required to report on your use of funds. They posted a list of data elements that will be collected in that reporting process, and note that they will be opening a reporting portal on or around January 15th, and that providers will need to report on their use of funds on eligible expenses by February 15th for any expenditures in calendar year 2020. There will be a second deadline for any carryover money. So if you don't expend all of that provider relief money in 2020, you can use it in the first half of 2021. And then there will be a second deadline in July 2021 to report on those expenditures. There is currently not an additional quarterly reporting option that was included in the terms and conditions early on. HHS clarified that those recipients don't need to do anything special over and above the standard reporting on the left side there. But there is an audit requirement if you expend more than $750,000 in federal funds in a year. So these that is not part of this program specifically. It is a longstanding federal regulation, but these funds are considered to be part of that. And so if you are expending that sum of money, you would be just be aware that you would need to comply with a single audit. I have some resources here that are available to help answer lots of questions in regards to this program. The Provider Relief Fund landing page and FAQs on that page are consistently being updated by HHS as they continue to administer this program. The hotline is also available, that 866 number, for any questions about outstanding applications or completing an application or waiting for any money. It's operated by Optum and United Healthcare, which have been contracted by HHS to distribute payments. So if you hear that, that's why. There's also the timeline that I mentioned, so reporting by February 15th or 45 days following the end of calendar year 2020. And finally, the need to attest to each payment received from the fund within 90 days. And we do have this PRF resource that outlines everything in great detail available at the bottom. The other really significant program that was created by the CARES Act was the Paycheck Protection Program. And this was geared not just to medical groups, but to all small businesses across the country. But I know that many MGMA members did apply for and receive these loans. So the PPP loans opened up back in April as well. But there was a subsequent piece of legislation that created additional flexibility in the program. They lowered that requirement that 75% of the loan be spent on payroll expenses to just 60%, so that you could use up to 40% on non-payroll expenses. It also extended that cover period from 8 weeks to 24 weeks to give you more time to spend the loan proceeds, and made some changes to deferment and the maturity term, and as well as safe harbors related to loan forgiveness. So here's a quick update on actions that have occurred through the PPP. That first round of PPP went really quickly at the beginning of April, and so additional money was added to the pot. And there was a second round of applications that began back in June, closed in August 8th with $140 billion remaining. And so I'll touch upon that in a second. But at this point, as the SBA is processing loan forgiveness applications. So that is the main question. If you received a loan and have yet to apply for loan forgiveness, there are 3 different loan forgiveness applications that you could use. Those are outlined here. Essentially, there's their standard version, the EZ version for those that haven't had reductions in hours or FTEs and salary levels during the covered period, or are sole proprietors. And there's also a simpler application for recipients of $50,000 or less. You can elect either a 24-week or 8-week covered period, and payroll must be prorated for whatever the duration you select, so that an annual salary per employee does not exceed $100,000. Again, this is a very dense program created around tax law. So I encourage you to take a look at our resource and also the SBA's loan forgiveness FAQ if you've got questions, and definitely to work with a tax professional for help in completing the loan forgiveness process if you have questions. I do want to just make some projections on this program just because it's seen so much attention over the course of 2020. The House and Senate are still looking to make adjustments to this program in the form of further legislation. So proposals include allowing you to deduct additional business expenses, including PPE and other safety equipment using PPP funds. There's also the question of tax deductibility of these funds. I mentioned there's $140 billion left in this program. I think Congress will likely open that up to another round of applications and potentially will allow small businesses to take a second PPP loan if they would like to. And there are also initiatives to streamline the loan forgiveness process for recipients up to $150,000, up from $50,000. So there is likely further legislative action that we'll see on this program. At this point, not really sure if this is going to happen by the end of this year, but likely in 2021. And as a reminder, if you do have one of these loans, you will not see any interest on the loan until 10 months following the end of your covered period. So it buys you a lot of time to complete the loan forgiveness process if you're running into some confusion. So that's an option sitting there. So for example, if your covered period you elect to end in November of this year, you would not see any accrual of interest until September of 2021. I want to end this section by talking about, I guess this isn't the end. Just kidding. But I do want to talk about the Accelerated and Advanced Payment Program that was expanded under the CARES Act. It is a long-standing program within CMS, but it gave applicants the opportunity to receive a loan directly from their Medicare Administrative Contractor, or MAC, approximately worth 3 months of historical Medicare payments. And so these were distributed very early on in the COVID-19 pandemic ahead of the provider relief fund. So many providers opted to do this. Originally, the repayment terms for these loans, however, were going to create lots of difficulties in cash flow for practices. So MGMA and others engaged in advocacy, and Congress made adjustments to the repayment terms for this program. So recoupment of these loans will no longer occur until a year after the disbursement date. So most practices received these in March or maybe early April. So you won't begin seeing recoupment until that date in next year. They've also extended the repayment timeline so that your per claim recoupment would not be at 100%. Now it's 25% for that first 11 months after waiting a year, and then up to 50% for an additional 6 months, which would bring you to September 2022. If your loan, for whatever reason, is not recouped in full by that point, the remaining amount would be subject to a 4% interest rate. but you can at any point opt to just pay this back directly to your MAC. You should be able to contact them directly to do that if you want to avoid this whole recoupment process, which would be set to begin automatically if no action is taken. This is the end of the section, which I can hopefully breeze right through, because if you are, have begun engaging your patients via telehealth since the beginning of the COVID-19 pandemic, you likely already know a majority of this. But the fact that we are in a public health emergency at this point allowed HHS to enact a lot of flexibilities to connect with patients by waiving geographic limitations, originating site restrictions, all different kinds of modality flexibilities, and HIPAA non-enforcement, which are outlined on this slide. But that's to say all of these are one for Medicare specifically, those flexibilities. Many private and commercial insurers have adopted similar flexibilities, but on differing timelines, which has of course created a headache for practice administration. We're tracking a lot of the major health plans in our commercial health plan COVID-19 policy resource on this slide. But on the Medicare side of things, all of those flexibilities are in place through the end of the public health emergency, which needs to be renewed every 90 days by the Secretary of HHS. It's currently set to expire January 21st of 2021, unless it's renewed again. We haven't heard at this point whether it will be or not. In the past, the Secretary has left it up till days before to renew it. Interestingly, this date happens to be the date after Inauguration Day. So we'll see if that affects anything. But in all honesty, I do anticipate that the public health emergency will continue to be renewed, and MGMA is engaging in advocacy to ensure that, and also to ensure that telehealth flexibilities are in place even beyond the end of the public health emergency, so that practices don't face a cliff when the public health emergency does end. I do want to put this again in the context of the final 2021 Medicare physician fee schedule that was mentioned earlier. CMS finalized a lot of permanent and temporary additions to the covered telehealth list. And so this is set to begin 2021 for the permanent, and these things that are temporary additions should already be covered for the public health emergency. But of particular note, these items on the temporary side of things will be covered through the end of the year in which the public health emergency ends. So given that it's already been extended into 2021, you could expect all of those codes to continue to be covered through at least December 31st, 2021, or the end of the year if when the public health emergency does finally end, if it's later on. So we're getting towards the end here, and I do want to do a quick congressional outlook. I hope I'm not going too fast through all of this stuff, so please chime in with questions. If I see any come in, I'll pause and answer, but I'll leave some time at the end here. So the big question for Congress is, what is going to happen for the rest of this year? Will we see another COVID relief package? I do not have an answer. It seems to be changing day to day. The news keeps reporting, that there's some sort of a bipartisan agreement for a $900 billion package, and then, it's got support one day and doesn't have support the next day. We don't really even have full details on all of the bills that are included in that package. And so it's just something we have to continue to monitor. However, this date of December 11th is coming up really quickly, and that is the date when government funding is set to expire. So Congress needs to take some action. It's possible we'll see a 1 week extension if they can't come to really any agreement at all. But short any action, we could see a government shutdown beginning December 12th, which is later this week. I am not thinking it's hugely likely that we'll see a full COVID relief package passed this week, just because there's been so much disagreement along party lines, and inability to come to a compromise on the number that would go into that stimulus package. However, what was more likely is to see a continuing resolution like we saw at the end of September that funded the government. And then there were also some certain COVID related provisions included, like those AAP advanced alternative and advanced, accelerated and advanced payments through CMS. Those repayment conditions were changed and tacked onto the CR. They also extended the GPCI floor through the CR and things like that. So it's possible that Congress could include a continuation of the suspension of the sequester through a CR. Not really sure, what on top of that, other than extending GPCIs and whatnot again, would occur with the CR as a vehicle. But it's something we'll continue to monitor. And if you are signed up for the Washington Connection, I'm sure we'll send out some sort of an alert should any package be signed this week. Of note here, new members of the 117th Congress will be sworn in January 3rd. And I think at that point, they'll be really quick to continue negotiations, especially if no full package is agreed to this month, that it will then resume in January. And of course, there are some interesting runoffs happening in Georgia that will affect the balance of power in the Senate. As it's looking now, it might be just more of the same in terms of the balance in power between the House and Senate. Yeah. But regardless of those things, what we're looking at for next year, we do expect that there will be certain items that are coming back into play on the congressional side of things. Surprise billing, we talked about a lot before the COVID-19 pandemic, and we have reason to believe that that will come back into play once vaccines get distributed. And so this would essentially protect patients from high cost out-of-network care. And we think it'll be talked about again. Even into the end of this year, drug pricing has been talked a lot. And we even saw some administrative action in the form of the most favored nation rule that was put out last month by the administration. But I think that Congress may weigh in on this particular issue in 2021 as well, just because it is seen as high priority on both sides of the aisle. And finally, protection for pre-existing conditions, which exists through the ACA currently, but I do just mention that because of the ongoing Supreme Court case that there were oral arguments for early last month. I mention this because the ACA is so expansive in the way that it provided, it really revolutionized the healthcare landscape just because of the way that it expanded eligibility for health coverage, made changes to minimum standards and EHBs, and even affected Medicare provisions. But it also created CMMI, the Center for Medicare and Medicaid Innovation. And so there's a lot kind of at stake in this lawsuit. And so I mentioned the Supreme Court heard oral arguments in this case early last month. In listening to those arguments, it did seem unlikely that the entirety of the ACA would be overturned. Some of the justices are more in favor of the severability of this individual mandate question. And so if, we can't make any predictions just based on oral arguments, but if we were, it's likely that the ACA will stand without the individual mandate. So again, we don't necessarily anticipate a final decision from the Supreme Court until probably spring next year, but at the latest June, which is when their session ends, and they usually save the large decisions until that point. I'll wrap up my discussion today with a discussion of advocacy and member engagement. we saw a lot of advocacy wins during the course of the COVID-19 pandemic. These are things that I and the team here in Washington have engaged both Congress and the administration on to for the benefit of medical practices. So on the telehealth side of things, getting audio-only telehealth codes was a big win, in addition to expanded telehealth coverage early on. The automatic MIPS hardship, suspension of the Medicare sequester until 2021, that was included in the CARES Act, and extension of the public health emergency multiple times at this point, and the change to repayment terms for the AAP, and finally, the financial relief programs that were created. We do have outstanding asks that we're continuing to try to engage Congress on. We would like Congress to take action to extend telehealth flexibilities beyond the expiration of the public health emergency, for CMS to create automatic MIPS hardships for 2020 and 2021. We're looking to Congress to continue to suspend the sequester so that 2% cut to Medicare payments doesn't come back into play for the duration of the public health emergency. And then regarding that conversion factor decrease that CMS finalized, we're looking to Congress at this point to waive their Medicare budget neutrality requirement, or at least hold providers harmless from seeing a decrease to their Medicare payments. So that would be supplemental payments on top of those Medicare payments that would essentially maintain no change from 2020 to 2021. We're endorsing a couple different bills, and you could read about them on our website, and I'll plug that in a second. And then we're hoping on the administrative side of things to get further clarity on the Provider Relief Fund and reporting for that program, addressing the tax treatment, and finally some amendments to the Paycheck Protection Program that were mentioned earlier. So you can help advocate as well. So we've created a bunch of grassroots letters that are available at mgma.com/contact Congress. If you want to get behind any of these budget neutrality, sequester, telehealth bills, we've got grassroots letters for really all of those things. And anyone could go on there, regardless of national or state membership, to complete those forms and send letters directly to your congressional representatives. So I highly encourage that, especially this week, as we're hoping for action to be taken by Congress to benefit medical practices. Again, we're here to be your voice, and I hope to get feedback from you all in the form of questions at the end of this section. But I do consider this to be a feedback loop. So just presentations like this, and a lot of what we do on the state side, whether that be through resources, through just phone and email conversations, through our member communities, grassroots letters, the Washington Connection newsletter, all of that feeds back into what we do here in Washington on the national level, both through Congress and in working with the administration. And so it is really important that we engage and hear from our members across the country. So you can do that, again, by signing up for the Washington Connection newsletter that goes out every week. We do have a designated phone number and email address to speak with government affairs staff, and national members have access to the member e-groups that have been incredibly busy throughout the COVID-19 pandemic. So I'm going to end at that point, and I can now open it up for any questions.
Thank you, Matt. I really appreciate that. We do have a question. Are there any state level efforts underway making their way to the federal level?
I'm not really certain in that regard. I know our office doesn't tend to track state level legislation. We do, I engage with what we have our legislative liaisons for each state that help to circulate important legislation up through us and share that with other states, but I'm not aware of any at this point.
Yeah. I'm wondering if our next speaker, David Thompson, is on the line, and it might be something that he would hit on in the next couple minutes. Are there other questions for Matt, I have heard you give this presentation now a couple times, and every time it's different and it's just so interesting and informative to everything that the practices are dealing with. I really appreciate it. Are there some questions um, that you'd like to put into the chat box? Matt has his contact information here, and I know that he is very responsive to emails and phone calls. I want to thank you, Matt, very much for presenting today. As I mentioned in the chat box, we are recording the presentation today, so you will receive the full recording, or all of our registrants will receive the full recording and the slides from the presentation by the end of the week. I want to thank you, Matt, again for joining us. I am going to now introduce our next speaker. David Thompson is the Senior Director for Legislative Affairs at the Pennsylvania Medical Society. David began his tenure with the Pennsylvania Medical Society in 1988. As part of the Society's lobbying team, Mr. Thompson has focused his efforts on building political awareness within the physician community, while at the same time educating lawmakers about physician issues that may affect their constituents. During his 8 years as executive director of the Medical Society's Political Action Committee, Mr. Thompson helped to create and manage a number of statewide physician grassroots campaigns for judicial candidates. Matt was our federal legislative expert, and David is here to give us the state perspective. So I thank you very much for joining us, David, and I'm going to let you take it away.
All right, thank you very much, Aaron, and I appreciated listening to Matt's presentation as well and hearing a little bit about what's happening in Washington. I'm going to kind of break up my presentation, and I should say parenthetically, I do not have any exciting graphics or any screens to share. So what you're seeing now is it. So I apologize for that, but hopefully we'll be able to keep things moving and keep things interesting. I'll start with politics, and I'm going to talk a little bit about politics, the election, what's happening legislatively in Harrisburg this last year, and what we're looking to see in the year ahead, and then talk a little bit about, as Matt did, about advocacy. First, let's talk about the election. I'm sure all of you are exhausted from hearing about the election. Exhausted from hearing about results and contested races and fraud, et cetera, et cetera. Let me just share a couple insights from a state level that you may find interesting and how they relate to what we're doing here in Pennsylvania. We have seen some interesting dynamics in this last election. Obviously, there's a lot of contention at the federal level in the presidential race. But interestingly, here in Pennsylvania, we saw Republicans pick up seats, both in the Senate and the House, which was a little unexpected given the polling we saw prior to the election. And we really did not expect to see Republicans gain seats. And I'll explain a little bit about why that's important to us. The current mix in the Senate is 29 Republicans, 20 Democrats. One seat, like the presidential election, one seat has yet to be resolved, and it's not been officially reported yet, and that is a race out in the Pittsburgh area. State Senator Brewster, who is an incumbent, was being challenged. His race, unlike some of the other races you're hearing about around the country and with the presidential election, Senator Brewster's race is down to 69 votes. He is ahead by 69 votes. That number has fluctuated back and forth. I don't know when that is to be officially called. I expect here before the 14th of December. But in any event, that is going to change, very little relative to the control of the state legislature in the Senate. But it is kind of interesting to see that we have our own sort of down to the wire race right here in Pennsylvania in a state Senate race. In the House, the current Republican-Democrat split is 112 to 91. Again, the House Republicans picked up 3 seats, which were unexpected and expanded their majority. which for many of our activities is good for us. However, we are certainly a bipartisan organization. We don't care whether you're Republican or Democrat, as long as you understand physician issues and understand how those issues directly affect constituents in your districts. So, we don't really care about partisanship necessarily. Interestingly, here in Pennsylvania, we are excited. There was some retirements last year, and there's been some new leaders elected, both in the Senate and in the House. And in the Senate, we're very excited to see that State Senator Kim Ward is going to be the new Senate Majority Leader. The reason we're excited, obviously, she's been a good friend of ours, but she happens to be married to a physician, which certainly adds a much, much different perspective on the profession and when it comes to legislation. So Senator Ward will certainly be looking as majority leader much more critically to pieces of legislation that affect the practice of medicine. Her husband is a nephrologist who practices in Westmoreland County. I also say that because Kim has been very good over the years on a whole host of issues with us. And we have had other state legislators who have had family members in the medical profession. This obviously is the first time we've had in the Senate, first time we've had a senator married to a physician, which is great news. We also are fortunate in the Senate to have Jake Corman. Jake is now the president of the Senate in Pennsylvania. He is from State College, Pennsylvania. Jake too understands medical issues and physician issues. His sister is an ophthalmologist who practices in Bedford County. So it is good to see that we do have, some folks in the legislature who really understand what's happening in the medical profession. Sometimes it may not be great for them to go home at Thanksgiving and Christmas because of the discussions, if they don't vote the right way for us, but still it's very helpful to have them on board. We also, on the House side, there have been some new leaders that were elected on the House Republican side last year. Representative Brian Cutler, you may be hearing a little bit about him in the news. I know President Trump has been trying to work with him and work on him to have the legislature do some things to help overturn the election. So you'll hear Brian Cutler's name a little bit in the national press right now. But Brian has been a very close friend of ours, very, very good on medical issues. He was a former X-ray technician, worked very closely with physicians at Lancaster General Hospital, really understands very, very intimately the whole hospital-based practice, what physicians deal with in the hospitals, understands what physicians are dealing with outside the employed setting. So he really has a great grasp of what goes on in the hospital, and frankly, pretty impressive for a guy who spent most of his time in the dark in the hospital looking at X-rays. So on the House Democrat side, we're excited that Joanna McClinton, who is an extraordinarily bright woman, she's an attorney. She is going to be the minority leader in the State House, which again is very exciting. She comes from Philadelphia, Pennsylvania, comes from a very, very different perspective with what's happening in the city of Philadelphia relative to healthcare. Her community, she is African-American. Her community and her legislative district obviously has struggles relative to access to care, et cetera, and insurance coverage and all those kinds of issues. So Representative McClinton, I think, comes to the table as the new minority leader in the House with a great perspective and understanding of what physicians are dealing with, but also is very, very sensitive to what her constituents and what patients have to deal with as they go into the healthcare system. Let me switch gears a little bit and talk about legislation. For the last 2 years, and for those of you who don't know, Pennsylvania has a 2-year legislative session that begins in January and ends 2 years afterwards on November 30. So right now we're sort of in a limbo time between November 30 and what they call swearing in day, when they come in on January 5th to swear in the new legislature. But, you know, it was, despite the pandemic, it was a busy 2 years. I have to say, I personally am a little disappointed that we didn't get nearly as many things across the finish line as we had expected to and hoped to. But there were some positive things that happened. And let me start with the positives. We're successful in getting a gag clause piece of legislation passed. If you recall, a few years ago, there was a lot of talk at the federal level, excuse me, about the issue of pharmacists not being able to share with customers coming into the pharmacy if there were low-cost alternatives for drugs that were being prescribed to them. There was that gag order, if you will, from the PBMs and the manufacturers, largely from the PBMs, that pharmacists were sort of, their hands were tied. They weren't able to tell patients and their customers how to save a few dollars. Legislation was passed at the federal level. This legislation that we got passed sort of closed the loophole at the state level. So the bottom line is there's no need anymore for a patient to come into a pharmacy and not be appropriately counseled on potential cheaper alternatives for their drugs at the point of sale. Tobacco 21, we were successful along with other coalition members to get the age of smoking increased in Pennsylvania to 21. That is a national wave, if you will. I'm not sure how many states have yet to do that, but it is certainly a good thing. And the last thing we had done was sort of a nuance. A number of years ago, there was legislation passed to mandate name tags for physicians and other healthcare providers to wear name tags identifying what they were. Were they a physician? Were they a technician? Were they a nurse practitioner or a physician assistant? A lot of times patients were complaining they didn't know who was treating them. For those of you who are working with practices that are spending a lot of time at the hospital, you may be aware that hospitals are changing the color of scrubs that their employees wear to differentiate between different providers. So what had happened was this name tag issue sort of had a little bit of a backlash, not relative to the title of the healthcare provider, but rather having their full name on the name badge. And sadly, what was happening is patients who were not getting the care they thought they should get, or their loved ones were frustrated with the hospital, those individual providers were actually getting harassed at home because the patients and their families could see the last name and they'd look them up, and you can finish the rest of the story. So the legislation we got passed now does not require that the full name of the provider be on the name badge, only their first name, and of course their title. So those were three issues that, while they don't affect a whole lot of what all of you folks do in working with practices, it was issues that were important that we thought needed to get done this last legislative session. I'm going to go through a number of other issues that are still in play. And I say in play because in Pennsylvania, once a legislative session ends, pieces of legislation that have not been signed into law die at the end of that session. But it's very customary for those bills that have not gotten across the finish line. They are reintroduced, most of the time by the same sponsors, and they sort of pick up where they left off. So telemedicine is the first one I'll go through, because I recall that Matt mentioned telemedicine. We did get a telemedicine bill passed. We did get a bill passed in the House and the Senate, and the governor unfortunately vetoed it. I can tell you the reason for the veto was very simple. It was abortion related, which is very unfortunate. but the governor felt very strongly that he did not want to limit any healthcare service via telemedicine. And unfortunately, the way the bill passed in the legislature, it did prohibit the use of telemedicine for abortive services. And as a result, he vetoed the bill. We will be reintroducing that bill again, but quite honestly, until we can resolve the issue of the abortion language in that legislation, or from avoid having it be amended into a telemedicine bill, I'm not quite sure whether or not we're going to get that across the finish line. The bill really was important to us, important to all of you folks whose physicians do a lot of telemedicine. We wanted to make sure that individuals who were doing telemedicine were appropriately credentialed, wanted to make sure that a video component was available if patients wanted a video component, or if a physician wanted a video component. We wanted to make sure that providers were licensed in Pennsylvania. We certainly don't want providers from other states, or frankly, other countries, to be providing care here in the United States and in Pennsylvania specifically, if they're not licensed here. So again, I think you'll see another shot at telemedicine again this next legislative session. I just don't know how we're going to get over that really politically charged issue of abortive services being provided through telemedicine. Venue shopping. For those of you who have been paying attention the last couple years, we have seen the Supreme Court remove some very, very important or propose to remove some very important safeguards on the liability issue, and that is venue shopping. 20 years ago, the legislature passed some sweeping tort reforms that were very, very good, that resulted in a reduction in liability costs and the frequency for which physicians were being sued. And that is all good. One of the major components of those reforms was venue, meaning that if you had an alleged malpractice incident that happened in a rural county of Pennsylvania, maybe along the northern tier, Venango County, Bradford County, if you had an alleged incident there, that's the county in which the case had to be heard and tried. A lot of child lawyers like to pull cases into Philadelphia and try them in Philadelphia or Scranton or Allegheny County and Pittsburgh, where there's a little bit more plaintiff-friendly juries. So right now, the Supreme Court has not made a decision on that. They are sort of weighing that decision as to whether or not to remove that rule that they instituted some 20 years ago. We're hoping they don't, but we'll see. That obviously is very, very important. It may not be important in the day-to-day activities of physicians, but certainly every physician who practices medicine today, and especially here in Pennsylvania, we are such a litigious society that lawsuits are always on the back of everyone, every physician's mind when they're treating patients and providing care. So that's really important to us, that we do something to make sure that venue does not change and that there isn't a change with that rule. Matt referenced surprise billing. That is another issue that we have been working on for several years now at the state level. We anticipate again that something will happen next year. It really comes down to one basic problem, and that is, if you're an out-of-network provider and you're providing services in a hospital or services just in general, and you are treating a patient that is not, that you do not accept their insurance and you're not an in-network provider, currently physicians can balance bill those patients for the differences in what the insurance is paying and what their charges are. It's a big problem. However, really our concern is one of fairness, and we want to make sure that if a physician or a group of physicians feels as though they cannot accept a certain rate of reimbursement for services they provide, whether they're an emergency room physician, a radiologist, a pathologist, they seem to be the providers that are most affected by this. They should not have to accept a fee that the insurers are willing to pay. The question becomes, what fee then should they have to accept, or what the insurer should have to pay? And that's really what it boils down to. We would like to see some arbitration involved, so that the two parties come together and say, okay, I want $100, you want to pay $50. What's fair? It gets a little bit more complicated than that, but that's really what it amounts to. It won't surprise any of you to know that the insurers want to pay less, and the physicians want paid fairly. So again, I know that's happening at the federal level. We frankly thought something would move here in the next week or two in Washington. There's rumors to that effect that something is going to happen with surprise billing at the national level. But at this point, it's uncertain. But I can tell you for certain it's going to come back again next year here in the state legislature. Prior authorization, another issue that is extraordinarily important to every practicing physician. We are trying to get that reformed here in Pennsylvania. We've had legislation the last several legislative sessions to try to resolve some of those issues. We would like to see a whole host of reforms, not the least of which is if they give you authorization to do a procedure or prescribe a medication, whatever the case may be, then you should be paid appropriately for that procedure. As all of you know, oftentimes they approve something, but right on the authorization, it says this is not a guarantee of payment. And frankly, that's just wrong. So we're working through that. I think a lot of you might appreciate what I'm going to say next, and that is opioids. It's ironic how the pandemic, the COVID-19 pandemic, has sort of pushed aside the opioid epidemic, but it is still there. Legislators are still concerned about it. But we recently, in the last month or so, received some calls from legislators saying, geez, you know what? My constituents are having a hard time finding a physician to provide chronic pain management for them. What can we do to change that? And quite honestly, what we told them was, well, you passed a number of sweeping opioid reform pieces of legislation that frankly drove a lot of physicians to say, you know what, this is not worth it anymore. I don't do that much pain management. I don't have that many chronic patients that are in pain. So I'm just going to stop prescribing any narcotics. And that's unfortunate because patients obviously suffer. So now what they're looking at is how can we sort of unring that bell? How can we kind of roll back a little bit some of those reforms that actually are hurting patients and hurting access to care for chronic pain patients, which I think we'll all agree they are caught in the middle. Now, obviously, if they're a drug-seeking patient, if they're a patient who's trying to get medications to sell them, that's a whole nother issue. But certainly legitimate pain patients who need pain management, some of them in the rural areas of this state are having a hard time finding it. And then the concern is they turn to other drugs, get addicted to heroin or other medications, and then the outcomes are not very good. So we will be working with them to try to roll back some of those opioid laws and regulations that were passed in the last couple of years. I will ask you this, if any of you have suggestions for us as to how we might sort of soften some of those opioid laws that have been passed recently, if some of the physicians with whom you're working have said, you know what, I'm not going to do it anymore, what could we change that might bring them back into being able to prescribe medications for chronic pain patients? Any ideas like that, we would be more than happy to hear them and welcome them, because we are going to be working on legislation probably the first 6 months of next year to try to deal with that. Credentialing legislation, again, passed the House, died in the Senate. It will again be reintroduced. We keep plugging away. We get a little bit further each year, trying to help all of you who manage practices to get your physicians and your other practitioners credentialed much quicker with the insurers. As you might expect, there's a lot of hurdles. You all know about them, but frankly, the delays are sometimes ridiculous, just as they are with prior authorization. The last one I'm going to mention is a piece of legislation that was passed a couple years ago dealing with test results. I'm not sure how many of you are familiar with this, but it was largely affected cardiologists and radiologists, but certainly there's a trickle-down effect to primary care and frankly, any other physician who's ordering an imaging study. The idea was at the outset to pass a piece of legislation that made sure that patients were aware of their test results. You all know that when a physician orders a study, they go to the hospital, they have an imaging study done, whether it's a CAT scan, a nuclear stress test, etc. The results are sent back to you as the referring physician, and then you call the patient to discuss the results. What has happened is a couple of legislators had instances where they had constituents whose primary care doctor or the ordering physician never followed up with them. There were some bad outcomes. So they passed Act 112 in 2018, that requires the individual who is reading the test results, so the radiologist or the cardiologist in the case of nuclear stress, to directly communicate with the patient that the test results are done, that they need to reach out to their referring physician, et cetera, et cetera. The reason I say some of that trickle down may affect some of you is that a lot of times patients were then calling physician offices saying, I understand my test results are done. I'd like to talk to the doctor about them. Why didn't I get a call? And the physician may not have even had time to review those tests and those results. So we're trying to roll that back and we're trying to change the way that's done. We want to still ensure that patients get their test results. That obviously is very, very important. But at the same time, we want to make sure the appropriate clinician is talking to them about their test results and not necessarily a radiologist or a cardiologist who may not really understand the history of that particular patient and may not understand how those results relate to that patient's underlying conditions. So those are the big legislative things that are happening. Again, all the ones I mentioned, they've been sort of in the mix for the last couple of years. They will continue to be in the mix as we move forward in next session. The last thing I want to mention, and I'll be very brief because I know we're up against the end of the session, and that is advocacy. I really, really implore all of you to engage in advocacy. Please try to get your physicians to engage. I know it's extraordinarily difficult. They are busy professionals. They do not want or like to take the time to get involved in the legislative world. They feel like they don't understand it. They feel like they're sort of a fish out of water. But you know, I can't impress upon you enough how important it is for a physician to take a few moments and call a legislator about a particular issue, even call a legislator and say, hey, I'd like to stop by, introduce myself, maybe grab coffee or what have you, just to get to know them. Obviously, with the pandemic, that is difficult, but a phone call is certainly fine as well. So I really hope that all of you will encourage the physicians with whom you work to get engaged in advocacy. Again, it's frustrating. Sometimes it's not fun, but boy, I'll tell you, when legislators hear from physicians and they hear from their own physician constituents, and that's important, it makes a world of difference. The best avenue for reforms and for effective advocacy is that relationship between a legislator and their own physicians in their hometown and in their districts. It is just huge, and I can't impress upon you enough how important it is. So with that, Aaron, I will end and be more than happy to take any questions anyone has.
Okay, we have one right now. The Pennsylvania MGMA just completed a legislative survey. One item with huge support is to require all payers use the same standardized application as the basis for provider credentialing, such as the CAQH application, and that payers be required to reimburse providers for services rendered during the credentialing process once the process is complete. Have these issues been addressed previously at the state level?
They have been, and that is part of our legislation that was introduced and passed the House. It was House Bill 616. Again, we expect that legislation to be reintroduced again next session. And the CAQH requirements is in that piece of legislation. You might appreciate knowing that one of the comments we got back from the insurers is that, well, not all physicians participate in CAQH. And if you're going to require us to provide or to use the CAQH process, you may get some angry physicians because they may not want to go down that road and have to do everything that CAQH requires. And we said, you know what, we're perfectly fine with that because we think most physicians do use CAQH. The days are gone where it's a small independent provider who may not have done that and not had the sophistication to get on CAQH and complete all those online requirements. But today, that's not the case. But yes, to answer your question, it has been discussed ad nauseum, and it is part of our proposal.
Great. And at the end of Matt's presentation, questions was: are there any state level efforts underway that have then made their way to the federal level?
Yeah, I recall that question. Not that I can really think of. I guess the only one is, well, maybe there's two. There's the out-of-network surprise billing issue that is a state issue, but it's also kind of a federal issue as well. And prior authorization is another one. We've been working on prior auth for the last 4 years or so. We have heard that there is some interest in Washington to do national prior authorization reform. I don't know where that is in the federal mix. I don't think it's very far along. It certainly isn't as far along as we are here in Pennsylvania. But those are really the only two issues I can think of. Telemedicine, I guess, is another, but really a lot of that has to do with state licensure requirements, which really isn't a federal issue. So those are the only three. Mostly it's out-of-network billing, surprise billing, and the prior auth.
Great, thank you. Are there any other questions for David? I'll give a minute for them to be jotted down in the chat box. I want to thank David for joining us today. It was
Sure.
a program that we put together in a short time frame. I thank you for making time in your schedule.
Yep,
Uh,
happy to.
I know that this is a time of, as you said, great change and upheaval in the legislature at both levels. So I thank you very much for your time. I'm not seeing any other questions, so I'll thank you and I'll thank our attendees today. The Pennsylvania MGMA is happy to host everyone. I hope that some of you will consider attending our payer update next week. That you can see the information for that on the website. Thank you again, David, and our attendees. And we will see you all soon.